Here are some guidelines for the management of central venous catheters or central lines. You want to weigh the risks and benefits of placing central lines at a specific site based on individual patients. For example, if the patient's at risk for pneumothorax, for bleeding, or for air embolism, you might want to avoid central lines that further predispose them to those conditions. You want to avoid the use of a femoral central line since it can cause infections. You want to use a subclavian central line in most cases to avoid infection. It's the least associated with infections. You want to avoid subclavian access in patients that are in hemodialysis because they can have subclavian vein stenosis. You want to use ultrasound whenever available. You want to use the CVC with the least number of ports that you need. You should remove catheters that are no longer indicated. If a line must be placed dirty, you want to replace it within 24 hours for sure, but as soon as possible. You can use a guide wire only to replace malfunctioning non-tunneled central lines and not to replace infected central lines. When the guide wire is used, you want to replace sterile gloves before handling the new catheter. Chlorhexidine, iodine, and alcohol are all good for skin antisepsis. You don't want to replace an otherwise functional central line just as routine matter. Daily palpation of the dressing is a way to potentially screen for potentially infected central lines.